we have the pleasure again of having Miss Coletta Barrett bring together yet another wonderful panel for us. And the panel will be based on team-based care and interprofessional collaboration. And I'm going to let Miss Coletta introduce her awesome panel. I think you're on mute, Miss Coletta.
Thank you.
There we go.
Thank you. Thank you, Lisa and team. And yes, I'm so glad to be back with this great group of nursing leaders and excited about this second panel because it we talk about interprofessional collaboration, and as nursing, we know it's important. We're part of a larger team, but the challenge of looking at it across different sectors, which is what it's going to take. Because if our challenge is around health equity and addressing social determinants of health, if it were that simple and we could have solved it, we would have already done it, right? But we only know that only 20% of someone's health is really in the healthcare sector. And so therefore, that other 80% that we have to address is going to take a larger collective impact approach to really impact health. And so this panel is exciting because we're going to touch on that. We're going to talk about how we collaborate across different sectors of the industry to impact health. But we have some great panelists that are going to be with us, but I'm going to throw a curve to our team. I'd like to pull up our survey questions first, because I know that our panelists want to know who's in the audience. Who are we talking to? Who are we getting ready to interact with? And to me, that's really, really very important, so that because we want to make sure that we are intentional in how we approach our conversation and our sharings. And so you're very familiar with Menti. You've used it before. Make sure you get your cell phone out and either scan the QR code, or if you look in the chat section, Kelsey has just posted the link. I want you to please go on to the Menti website and pull up our first question. This is important. We want to know what your area of professional focus is. I want you to tell us, from looking at these options, I want you to let us know who's in the audience, who's in the room. Last panel, we talked about being around the table and who's in the room. We want to know who's in the room. So please go ahead and continue to populate. As you can see, some really interesting numbers popping up, not unanticipated, a large number of healthcare, but then let's look at people that about social needs and risk factors and determinants of health, that's their professional focus. And then looking at health equity, even from the perspective of we have the insurers and health informatics in the room. So some of these are really good for our panelists to know. All right. So thank you very much. And so we can see, our panelists can see where we are, more than half of the respondents are healthcare, and then we separate out in a few other groups: social risks, health determinants, risk factors, health equity, and then there's a split between insurance and policy. So why don't we go to our second question? And this is important because we want to ascertain who already in the audience is engaged and involved in multi-sector partnerships already. Using, the whole concept of it takes more than just one organization or one entity to solve large-scale social problems. Are we already involved in this, so that our panelists have a good idea as to whether we want to dig deeper into some of the basic concepts, or we're going to start from the basics and go from there. And so exciting to see that, over almost half of the people responding are involved in multi-sector collaborative relationships. And then some are very much involved, but just aren't necessarily directly involved. So this is good. This is very good insight for the group. So thank you all for doing that. And then our last poll that we want to make sure that we get, a pulse of the group is, within the organizations or where you currently work, are you screening for social factors or are you screening for social determinants? We read in the literature that healthcare says it's important, but what the data tells us is that we're inconsistent with it, and there's great variation across all factors about it, that we say we're screening for social determinants, but we may only be screening for one or two, as opposed to many of the domains that exist. So it looks like Dr. Dobbins and Dr. Jagno, you've got some very informed people and engaged people in screening for social factors or social determinants. So we're going to have we're not having a novice group here, ladies. We're going to be moving people along a continuum pretty quickly. So thank you all for participating in this survey, and thank you all for sharing kind of where you are, where you're coming from. And so now I get the pleasure of introducing this awesome panel discussion. We have two healthcare leaders here gathered for this presentation or this panel discussion. Dr. Tanya Jagno. Dr. Jagno is an LSU faculty. She serves as the Chief Medical Information Officer for Our Lady of the Lake in Baton Rouge, Louisiana. And she truly is the, I want to say the executive sponsor. Like I may be called the executive sponsor, but she's the executive sponsor for our social determinants of health work as it begins to scale and spread across our system. And so Dr. Jagno is a lifelong student, and so learning many different things along the way and sharing that readily. And Dr. Dobbins, Jess, as she wants us to call her, Dr. Dobbins, very interesting perspective and background when it comes to the health arena. In other words, being a representative from Humana and Humana's Foundation, she's leading their efforts as the Associate Director of their Equity and Community Engagement Network, working with academic medical centers across the United States to look at how we take learning and how do we translate that into actionable program services and efforts and initiatives that can truly make an impact on people's health. Now, you have in your meeting packet the program booklet that Kelsey just published. Again, they have a much broader bio than what I just touched on. But what we talked about was we wanted to make sure that we gave our time to sharing the knowledge and challenging the way when it comes to thinking about these things. And so what I'd like to ask is, Dr. Jagno, if you would start first, would you just tell our audience a little bit about the organization's mission and the commitment to addressing health equity and social determinants, at least from the perspective that you have as being the Chief Medical Information Officer to make that happen? Would you share your perspectives?
Sure. Thank you, Colette. And I appreciate the warm introduction. It's great to be here with such a talented group all around. I've been listening to the other sessions and learning a lot. I'm fortunate to be part of FMOL, Franciscan Mission, predominantly at the Lake, but we have reached out system-wide with this initiative to screen for social determinants and attempt to address them. Simple sentence, but really large, complex project to put throughout our system with all of our care providers, all disciplines. The idea, I give credit to Colette, she's being modest, is that we took it straight to the top of our system, the leadership, and said we need to do this. And this was before COVID really amplified what social determinants do to people and create almost a collapse of the community when we were sort of in the middle of that pandemic. So I give credit to the organization for recognizing the need before it was sort of blasting, out of the TV every day. And we went and said, we need to ask our patients these questions. We need to find out what's impacting their health, because as we look at social determinants, and just about every publication that reviews it, it's really clear that it's the 80-20 percentage, where you're doing great with medical care, but everything around you, your transportation, your home, your living environment is going against your health. We're not making an impact. And so we as healthcare providers, and my background is critical care. So, I was seeing the end result of a failure to address social determinants when they were modifiable, before terrible disease was present, chronic conditions were becoming acute on chronic conditions. And then with COVID, the amplification was that those who had suffered from social disparities, inequities in healthcare, access to healthcare issues, were really the sickest people, who were spending a lot of time in the hospital and needing a lot of resources. And so it's an interesting thing, is like, if you look across folks who, when you ask questions about do they feel this is important, and they may be in a situation where they don't say I've experienced it. And I was like, you did. In the community during COVID, we had a full hospital. We canceled elective procedures. We were short on being able to do things that weren't emergent and urgent or in crisis setting. So the entire community, even the most well off, and those who would score zero at problems with social determinants, were impacted by their presence. And so it's part of all of us as far as achieving health for our community. And so I got the green light, and what I like to call, from our president, Dr. Vath, the credit card. And go in, and I was like, we're going to do this because Dr. Vath said so. Although he encouraged me not to use his name as leverage, sometimes it's good to have the leadership on your back and say, this is the direction we're going. It's a Catholic mission, so all of our leadership, including our nuns, this is what we need to be doing. So that certainly made the approach and the tactics, the day-to-day work, the job, and the convincing part easy. And it's also hard for folks who are in healthcare, even though the difficulty of tackling social determinants is significant. It's not easy to ask questions. It's not easy to capture the data or measure the outcome. But when you say you don't want to take care of patients' health problems outside of the hospital or the clinic, and there's like, well, no, I do. And so it's easy to get rid of the resistance by calling out that you can't not recognize that this is very impactful, and it's essentially the direction we need to go when we think about healthcare. So that's been the journey. And hopefully I touched on that, Coletta, but I'm happy to expand, and I'm excited to hear about what Jess has, because this is truly going to be, the 360 of this approach from a healthcare standpoint, discipline, and then you have providers and payers represented here. So it's going to be an exciting hour. Colette, you're still on mute.
Dr. Dobbins, you want to share with us a little bit about Humana's journey and the mission and commitment to addressing the health equity and social determinants?
Certainly. Yeah, quick sound check. You can hear me okay? Wonderful. Well, first, just thank you so much for including Humana in this really important discussion today. And to all of you, thanks for taking the time to fill out the survey questions. What an impressive group. We have great representation from across the health ecosystem. So that's exciting. And Coletta and Tanya, it's just really been a pleasure to kind of get to know you and the work that you're doing. So thanks for including me. I'm really looking forward to our conversation today. I did see some insurers or insurance representation, in the grid. So many of you likely understand our kind of point of view and perspective in this conversation, but many of you don't. So I'll kind of give you an overview. As many of you know, Humana is a leading health and well-being company. We serve over 17 million members with our medical benefit plans, but we're much more than just a payer, of course. So our mission is to help people achieve lifelong well-being. We have high expectations for ourselves and our partners and suppliers in order to deliver the best to our members and the communities that we serve. Our commitment to serving social needs, risk factors, and determinants of health, as well as health equity, is evident by our work on multiple teams. One through our Office of Population Health, and also a new team, which is our Health Equity and Community Engagement team, which is the team that I'm on. So first, a little bit about Humana's Office of Population Health. We refer to it as our BOLD goal, named after its mission or goal to improve the health of our members and communities by developing and integrating solutions that address these unmet social needs. Humana is committed to improving population health at that community level. We currently have 20 what we call BOLD goal communities across the country, including Baton Rouge and New Orleans. These are places in where we're creating evidence-based, scalable, and financially sustainable solutions with community partners and physician practices. I'd be remiss not to mention the Humana Foundation as well. This is the philanthropic arm of our organization, also investing deeply in these communities through our grant-making portfolios and disaster response efforts, all focused on social needs, risk factors, and determinants of health. Similarly, our newest team, the Health Equity and Community Engagement team, which is led by our new Chief Health Equity Officer, Dr. Wando Alayawola. We're working in parallel to this BOLD goal mission to eliminate unjust, avoidable, and unnecessary barriers in health and healthcare. We have established health equity for our company as a key business and culture driver, and have begun to embed it really into our Humana products, services, and partnerships in order to improve health outcomes of communities, associates, members, and even within our kind of provider organizations to support them as they deliver optimal care. So I really look forward to digging into this a little bit more and sharing more about some specific initiatives from our BOLD goal team and our health equity team later on in this conversation. Thanks, Coletta.
Yeah, thanks, Jess. And I did want to highlight. You spoke about Humana's BOLD goal efforts and initiative in Baton Rouge and in New Orleans. And so part of this discussion is the multi-sector collaboration. And what I will share with you is that, and you may not know this, but in Baton Rouge, you lived that mission and walked that walk, in that the Mayor's Healthy City Initiative, or Healthy Baton Rouge, had been in existence since 2008. And when Baton Rouge was identified as a BOLD goal investment city, it was like, well, here's how we go into communities and here's what we do. And it was like, whoops, we've already got a multi-sector collaborative going on in Baton Rouge. How can we partner? How can we work together? And I raise that because it's an example of living the multi-sector collaboration of identifying where the gaps are and going to the partners that are doing the work. So you guys lived that in the Baton Rouge. That's the only one I'm aware of. You know, I wasn't involved in the New Orleans one, but it's just a validation that your team did what it says it's going to do.
100%. And certainly that is a big caveat. It's not as if, you know, anyone here on the line, especially not a payer, you know, invented the word social determinants of health, or, you know, have developed all of these partnerships. We're simply elevating the existing resources and assets and good work that's happening in the community, and leaning in to the extent that we can help and partner within these shared goals. So great call out, Coletta.
Yeah, and so Jess, you know, when you talked about sharing resources and elevating them, you know, can you share with the group here some of the significant investments that Humana has made in addressing social determinants? You know, what some of those investments are and the benefits that maybe you're seeing or you guys hope to see of those investments.
Yeah, you bet. And, you know, this concept is certainly not lost on this audience as practitioners and nurses and others, allied health professionals out in the field. You all know better than anyone, these risk factors, these social needs and determinants of health, they influence our health outcomes just as much, if not more, than any type of medical care does. So this is a big investment for our company. We're investing in screening, in testing, piloting, integrating these social concepts into programming and payment models. A couple of focal points for us are food insecurity, social isolation, and transportation. And I'll spotlight some of our food security programs for this conversation, but we'll also put a link in the chat that'll take you directly to some sites that offer a great overview of our broader portfolio of work. So food insecurity is particularly high among Medicare Advantage members, especially those with dual eligible special needs plans or DSNPs. So Humana has therefore really leveraged the Medicare Advantage value-based insurance design, or VBID model. And that happened in 2022. We wanted to leverage that model to support this population and offer the healthy food card benefit to qualifying members in several states. So this is an example of kind of a scalable, broad program to address food insecurity. The benefit can be used to purchase healthy groceries at various national retailers. And essentially, this is just a card. For those of you that aren't familiar with this, it's just a card that would be in your wallet, loaded with cash benefits each month. Now, in response to the pandemic, Humana also took advantage of CMS's flexibility to offer mid-year benefit enhancements, expanding the number of plans that actually offer the benefit, and also increasing the monthly allowance on certain plans based on need. And we continue to kind of test and evolve this offering by expanding the retail network and also just the usability of the card and benefit itself. It's certainly an iterative process, but a great example of how we've invested in that particular social need. Another more local example that I'll spotlight. I was actually just discussing local food security programs with Amy Blaylock. She is a population health strategy leader there in Louisiana. Amy has led Humana's partnership with the Second Harvest Food Bank for the Macon Groceries mobile market. Which is a mobile food market that brings nutritious foods at a very, very affordable price to food deserts there in South Louisiana. It's really a brilliant collaborative concept that meets a very important health-related social need. And from what I understand, as Amy described, there will be kind of some more collaborative innovations and enhancements around that. I think they're considering building in kind of a service co-location model and thinking about offering things like flu vaccines, maybe even diabetic eye exams in those same locations as the mobile market, with the intent to really increase utilization of some of these preventive services. One last plug I'll put in for the informatics folks, and of course, I know that Tanya will be really interested in this. Another key investment that we have is around the data. So you have to have good data to inform investments in these types of social programs and understand where those gaps are and where those needs are. So Humana has invested in various modalities and validated screening tools to screen members for social needs, risk factors, and determinants of health. I think according to our latest dashboard, in 2021, I saw we screened approximately 1.7 million members on various social needs. And in 2019, we administered the CMS Accountable Health Communities Health-Related Social Needs Screening Tool to about 430,000 MA members. I think approximately 100,000 responded to that baseline survey. So they were providing individual level data on things like financial strain, food insecurity, housing, loneliness, transportation barriers, et cetera. And these data enabled us to really understand the prevalence of health-related social needs and the effects of their cumulative burden on member outcomes, utilization, all of these things, of course, informing our business strategy. We've also built a number of analytic tools based on this data and put a lot of this work out in the peer-reviewed literature as well. And so I'll offer some links here in a minute where you can explore some of that. But after a couple of years of the coronavirus pandemic, we're attempting to resurvey this same cohort to better understand their needs, how those needs have changed over time. And this data will just really offer an important asset and resource for us to be able to ask and answer really important business and industry questions and understand a little bit more about the toll that the pandemic has taken on older adults enrolled in our MA programs. So I'll hand that off to Tanya. I think that'll be a good segue as she shares more about her passion for screening and data as well.
Yeah, thank you, Jess. And great segue and great conversation to plug into the informatics piece. I was happy to see we had a decent collection of folks in social determinants and informatics. The biggest bubbles were in healthcare. And so just to make sure we're all level set, if you don't work in the world of coding information, we learn to do a history, we do a physical, we document in progress notes what's going on with our patients, and then come up with a treatment plan and execute that. And that's really the focus of most of our medical education, whether it's nursing or going to advanced practice, becoming a physician. And so what's needed here is to understand that the social history, and what Jess just said was this tool that CMS has put out has become a validated tool. And the nice thing about it is most screening tools in major electronic health records are there. It's just not common practice. We usually just say social history. And for the most part is, do you drink, do you smoke, do you do drugs? That was the social history, 10 years ago when I learned. And there were a few other things that have been added to that. But we have it as a side comment from the history and the other components. And we really need to elevate that to, it's a major part of what dominates the patient's health. So getting into this transition of, we have to ask the questions that Jess just described. Do you have difficulty getting to the doctor's office? Is that a transportation need? Do you have difficulty getting your medication? Are you financially insecure? And that sort of spills into others like home security, not having a safe place to live, all of which contribute to medical conditions and exacerbations. So when those are answered in sometimes a Likert scale of, sometimes, never, always, you're starting to tell the story. And then ultimately what we like, and most, again, electronic health records require you to codify that data. No matter how much you hear about it, it's great to hear about natural language processing. We're still far away from being able to read someone's notes, even if it's typed in and, nice and pretty. It has to usually get into a definition or a category. And so Medicare has really encouraged the use of Z codes, which is once you say yes on the survey, then we sort of pair that to, it's a condition. It's a condition of financial insecurity. It's a condition of food insecurity, social isolation. And so when that's coded, that to me is the major selling point when I talk to physicians about doing that, and they say, I'm so busy, I can't be the social worker. I agree. We want you to do what you do best, but you have to tell the story to let folks at Humana know what's going on, so that all those programs are directed to their members, or Blue Cross or Aetna or United. You can flip the names, but the statement that we would like our insurance companies to address this, they are. And they do recognize the value. And we're on the call with this passion about, we're here to take good care of people. There are bean counters that are out there going, it's actually a financially good investment to address social determinants before it becomes an expensive condition. As I was reading and preparing today in some of the publications, there is a 5% increase in cost for every positive social determinant in one of these studies. And so if you think about it, there's 11 to 12, and you have your pre-existing conditions, that's really expensive. And so it's a wise thing to say, we're going to offer these resources to our patients, but you have to tell us what's going on with them. Just like you tell us that they have arthritis or coronary artery disease or diabetes. And so we have to crosswalk that. We have to recognize that in our system, as we care for folks and delineate their history into essentially a communication tool, which is for some Epic, for some Cerner, for some Allscripts, several different ways of getting there. Most of the screening tools, however, touch on the same subjects and can ultimately be in a common definition of the ICD-10 coding, which we all usually are familiar with. That is how we tell the story. So that is, it's in a place where we can do analytics and we can do large scale number counting about our patients. But that journey involves a very intimate conversation about, let's sit down and talk about not having enough to eat, not having enough money, being abused. It breaks into this area of who accesses their patient's medical record when you have a proxy, and particularly with underage patients. So, you have a spectrum of infants to children to teens, and within there, the teenager becomes the primary person accessing MyChart, and being able to get the information from the adolescent with their concern about who else might find out that, I do sometimes smoke marijuana. If my mom finds out, maybe I'm in trouble. And so we have to navigate that pathway of the sensitive conversation and codifying it into a language that allows the action to happen. The second great point, and I think when I listen to Jess talking about their programs, is it's very hard to measure the impact when you want to tackle social determinants. It's like saying, let's measure the impact of all therapies for cardiovascular disease. You can't do that in one big bite. It is specifically, let's look at atrial fibrillation or having coronary artery disease and having stroke. There are channels where you start to work in. And so it's no different with social determinants. There are problems that are specific to communities, that are specific to patients, and the solutions have to be the same. You can't just say, here's money, go fix financial insecurity. It's potentially some folks who show up that are underinsured. They have insurance, but they can't access care because there are deductibles and there's other things in place. And so there really has to be very specific measurement of the specific programs to say social determinants are important in healthcare. If you try to do it on a global scale, we fail because we can't capture all of the complexity. You also can't just throw unintentional programs at problems. They have to be very specific to solve some of the problems. So putting these food resources and healthy food resources where you've identified food deserts by doing some background information, what's the collection of folks who live here? What's the financial status in the zip codes when we know that they dictate your life expectancy? You're going into places with an understanding of the situation to bring very specific solutions and also to assist the patients in assisting their own healthcare, becoming engaged. So I think those are the major points: is the identification, what is going on with our patient population that we serve, what are the needs, and be specific about those. Be able to analyze it. So you translate the needs into a language that we can use between providers, payers, the civic associations, the community, and some of that is in our third-party library resource folks. You may have heard of, I've used the term at Bertha, it's now Find Help, Unite Us, NowPal. They're these resources that you can send the information to them so that they can send the resources to the patient, usually on a mobile device. We're in a place where you can communicate directly to someone now because of the sort of the widespread use of cell phones and applications. And so taking advantage of that streamlined definition, having a good description of a community and also of a patient's needs, and then knowing that there are programs, particularly within the payer space, to connect them to. They're just sitting out there waiting until we say we need this patient to take part in Humana Goals programs. If we don't ask the question and connect them, then we're not making good use of the resource, nor are we getting the full benefit of providing health to our patient by getting the complete history and communicating that to those that are providing it, very much like I write a prescription and they go to the pharmacy. And that, that lays out that's how it needs to be treated. It's a health condition. You identify it, there's a resource to treat it, just like there's a disease and a condition, and we connect all the way to the patient.
And I like the way that you brought that back around to the patient, because as we would say, no matter where we're working, that the patient is at the center of what we want to bring. And so at this point in time, what I'd like to pose to you is that, Dr. Jackno, you represent the voice of healthcare delivery. Dr. Dobbins, you represent the voice of the payer sector. How do you see that your sector supports interprofessional collaboration, or what is it that you want to see enhanced from your partner? So like Dr. Jackno, you're going to talk about what you want to see from the payer perspective as we say the patient is the center of this. What do we want to see in collaboration more with our payers? And then Dr. Dobbins, you're going to get counterpoint, and you're going to be able to share with Dr. Jackno how you represent your sector, how you see we need to work this together. What do you need from each other to make this work?
So, I think it's happening, but I'll say that it's not at a place where it is widespread. But all of the great things that Jess just described are not known to most providers in the ambulatory setting. And what you need is usually these intermediaries. We have social workers and case managers who know that space, but providers don't know and rarely visit the website, I would say. And I hate to say that I'm the speaker of ambulatory practice because I'm an intensivist, but I've had a lot of conversations with them, and it's mostly about a lack of awareness that this resource is available from a payer. And being able to get what you do, ideally to some of these libraries that we can connect our electronic health record to, and at the point of care, recognize and immediately connect to what their payers have to offer. I think making that space more efficient, what I call the iPhone rule. No one reads the instructions to iPhone. It's intuitive. You turn it on and you talk. Despite the complexity of what goes on behind a working device like that, it just works. And so being able to fill in the gap where not every ambulatory practice, not all primary care providers have access to that social work resource or someone to do the research. What is your insurance? Let me go on the website. Let me find the programs. Look, they will pay for you to have exercise at the YMCA for free. Your Silver Sneakers programs or things like that. It requires time that providers, they don't have. Whether they do and they're inefficient or they're really busy, and I think that's more the case, being able to explore what's available to patients. We have a gap there with a sort of a clinical worker or a coordinator. And so how do we bridge that? And it potentially has to be technology, sometimes directly to the patient and directly communicating with them. Small request, Jess, just fix all of the communication there.
Right. Well, it's a good question. And my mind goes a little bit more to the relationship itself. And you had asked about the multi-sector partnership to support social determinants of health and health equity. We know that these multi-sector partnerships are good, right? We know that kind of intrinsically, but then there's data that kind of explains why it's so important. There's evidence to suggest that these kind of more connected communities that are leveraging multi-sector partnerships to promote population health activities, to address unmet social needs. The more connected those communities are, the lower their rates of preventable mortality, for instance. We've even seen lower healthcare spend in those really connected, collaborative communities. We know that these multi-sector partnerships, it makes sense, right? They help us get to where we want to go because we're pooling resources, we're coordinating efforts, we're reducing duplication. And this kind of expands our broader capacity to get at these unmet social needs for communities. But it's really hard work. It's hard to engage in those partnerships. So as I think about what we might need from the healthcare kind of sector, I don't know. I'm gonna kind of beg out of the question, Coletta, and I'm going to say that it actually applies to the broader health ecosystem, including the payer. In that, one thing that we might look to enhance is that investment in those multi-sector partnerships, because they are so hard. Unlike the iPhone that just works, partnerships don't just work. You got to really work it. So I think continued investment and commitment to that transdisciplinary work, really the coming together, that synergistic effect that we see within those types of partnerships. So getting away from transactional exchanges. Just because you have someone else on a paper or on a project from a disparate sector, that doesn't mean that it's real collaborative work.
Right.
So really putting that emphasis on that partnership and that relationship. I'll say too, as it relates to that, this is going to be a paradigm shift and a bit of a shakeup for a lot of people. We saw that some people are engaging in multi-sector partnerships, but many aren't. And that's because it's new, it's uncomfortable, it's very, very challenging. We don't necessarily have the systems or infrastructure to support those partnerships. We might have different goals. We might have different incentive structures, and it makes it very challenging to find that shared meaning. So this will require a bit of a shakeup, and that might mean that we're taking on new roles and responsibilities within these partnerships. That might mean that the person in the white coat is no longer making all of the decisions. That might mean that the payer is really having to step up and offer more than just data and funding. We might be looking to the patient and the community and even the student population for different levels of new dynamic leadership. So yeah, it'll be a real paradigm shift, but a commitment and an openness to those kind of new possibilities as we think about multi-sector partnership. That's kind of where my mind goes.
Yeah, you bring up this collaboration along a continuum, depending upon what the outcome that we're looking for, as to what the dynamics around the table are. And lots of times healthcare, no matter what part of healthcare, whether it's healthcare delivery, ambulatory, acute, the payer side, the policy side, you come to the table from a position of power. Well, guess what? In many of these multi-sector collaborations, we have to take that off the table and function from a position of seeking to understand first and then going where we're requested to go, as opposed to telling people where we need to go. So it really does take a different skill set and a commitment to be able to do that kind of work. So it really is important community work. Dr. Jagno, you were going to speak about that?
Well, I want to call out, because we mentioned collaboration with partnerships. It's, call out some names there. So definitely the healthcare system. And within healthcare systems, there are networks that are usually grouped by, maybe accountable care type policies. So you have these metrics to meet. We have payers, which are, the biggest one being the government, Medicare. But we have private insurance and we have Medicaid. And we sort of bring Medicaid out because it's different in the sense of, what is offered to the patient. It's insurance. And it's very different in Louisiana versus California versus Michigan. And it's something that you have to understand when you're dealing with what does the patient need and can we get them to what they need. I would put employers in there. That's a big negotiating point, because it's good for Walmart to have a healthy workforce if they are ensuring their workforce and they're working. They need their folks to show up. But now more than ever, we need people to do the work that we didn't realize until 2 years ago, 3 years ago was essential. We've redefined what that means whenever you don't have folks driving trucks and doing certain jobs that we considered less essential, now is really brought to the forefront when you get into these discussions about we're short on people to do the things that we've gotten used to that brought us convenience. And so that workforce needs attention to health. And the bigger component of that, I feel employers make a huge impact when they partner with payers in addition to providers to go, we all together want this group of people to stay healthy. And we also want to make good choices about their health going forward. And so those partnerships have the skill sets and the technology and the resources to do the connecting. We just haven't got it all together yet. We haven't sat at the table and sort of listened and seeking to understand, like Colette said, so that we're not working separately on solving some problems that require the connection. And we're guilty in our space too. And like we tend to have healthcare entities that are, in competition with other healthcare entities. And that, I think, sometimes needs to be broken up so we all come sit at the table and take care of the community together, understanding that as we exist, major health systems may sometimes be across the street from each other. But if you work alone, you will go a very short distance. You will work better together and go further if you consider that you're there as a need for the community. So, I just wanted to make sure when we're talking about those, it's a partnership of in the healthcare system, nursing, physicians, care managers, social workers, all critical pieces. And then there's above that layer, these partnerships that work together with the common goals that can execute at the level of a system and multi-system process. So I'll hand that back to Jess just to see if there's anything else, because from the payer perspective, you deal with a lot of healthcare institutions, in your case academic, and it adds a little bit of a twist to it, is that are we actually getting to the table and understanding the need to sit and have common goals together?
Well, I think we're getting closer. And, to your point, it will require trying some new things and maybe developing some unlikely partnerships for new solutions to these very, very challenging problems. Coletta, I know that you have a few other questions for us. I don't know if we want to get to those, or if you'd like me to just share a little bit about some of those kind of new and unlikely partnerships. I'm happy to share more about our academic stuff.
Yes, that's an important aspect I'm going to bring about. One of the comments in our chat session is about understanding and knowing how important collaborating partnerships are. And so if you would share some of those stories from the field with the academic partners.
Yeah. And, it sounds like a little bit of a cop-out, but every time we talk about different projects or problems, there's really no reason that every conversation should not be collaborative and interdisciplinary. And in my opinion, it really is requisite for almost all of the work that we do. And that commitment to those multi-sector partnerships, evident in the bold goal work that I told you about, and the coming together of those connected communities across the country in a myriad of ways. But also demonstrated in our strategic academic partnerships. And that's the team that I'm on, is within our health equity and community engagement team, our academic partnership team that essentially manages and supports and facilitates partnerships between academia and Humana, the payer sector. So the mission of our academic partnerships team is ultimately to establish these academic partnerships focused on interdisciplinary training to improve community health equity, advance workforce development, which was mentioned in the chat and as Tanya mentioned, and also to foster innovations and research. There's a couple key partnerships I'll tell you a little bit more about. Our newest is with the University of Louisville, where we just launched a health equity innovation hub in February of this year. This is a 6-year, $25 million partnership between the Humana Foundation, Humana Inc., and the University of Louisville to advance social and health equity for structurally marginalized populations. And it's aligned to those core pillars of community health equity, workforce development, and research as well. We're really excited about this budding partnership. It's just kind of evolving and developing now. But we look forward to seeing how we can improve health equity in Louisville, in the state of Kentucky, and of course, beyond. Another partnership that we have, an academic partnership, our first perhaps flagship partnership, is with the University of Houston, where we established Humana Integrated Health System Sciences Institute, which does not exactly trill off the tongue. We call it the Humana Institute. And it's made up of the university's 5 clinical colleges. So medicine, nursing, optometry, pharmacy, and social work. And we've had tremendous success, in the first, 4 years of this 5-year, $15 million investment. And there's a couple projects that I'd love to highlight, and I'll be sure to share additional links in the chat. But by design, when we have an intake form or a rubric to kind of develop and shape our collaborative work, we require multiple disciplines and colleges and business units to come to the table. The work doesn't even go forward unless you have those collaborators present. So one project that I'd like to share is a great example of that interdisciplinary, perhaps even you might call it a transdisciplinary effort out of the University of Houston, and it's a medical legal partnership program. So the University of Houston College of Medicine, the Humana Institute, we've teamed up with a local FQHC in Houston and a local legal aid provider to support patients' health-harming legal needs. So beyond these maybe more well-known social determinants of health and social risk factors like loneliness, food insecurity, as you all know, people are struggling with other things: workplace discrimination, disability issues, inadequate housing, and these issues require legal support. And if left unattended, can cause real stress and lead to serious illness. So one scenario, actually just recently, I was in a meeting earlier this week and heard this success story. A patient in the MLP program shared with their physician that they had mold in their apartment. Unfortunately, their landlord was unwilling to pay for the mold remediation and would not let them out of their lease. The patient was asthmatic, so these living conditions really posed a serious threat to their health. The physician was able to refer the patient to legal aid through the MLP program. Legal aid was then able to help them break their lease at no cost to the patient and get them into more suitable housing. So in theory, we might have been able to guess this scenario, but it just blew my mind to see that happen, documented, and to be able to support these complex needs that could only be possible through multi-sector partnership. One sector, really can't do this on their own. It requires that type of collaboration across the health ecosystem. So it was exciting to hear that actually work. And there's many other programs similar to that. And I'll be sure to share the MLP press release here in the chat so you can learn a little bit more about it. But I'll stop there and share my airtime with Tanya. I know that she has a number of other things to share as well.
Some of our participants may not know what MLP means. It's a medical legal partnership. Mm-hmm. It's a program that the American Bar Association, in collaboration with healthcare leaders and their health trust law group, come together and create these opportunities to advocate for patients that fall through the cracks. And so very, 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 very important program. Dr. Jagno, there have been some significant investments in higher education and cross-sector with acute care that you might want to share to highlight so that the people in Louisiana know what's been happening local too.
Sure. Great ending. That was a very specific prescription from the medical legal standpoint. That's a great example. And it's always rewarding when you hear the patient's story and the resource, and then, that it actually got carried out to a good thing. The mold problem is no longer causing asthma exacerbations because of the partnership, because of the connection. Coletta's raising a question. There's several things to talk about locally. We had the luxury of, from our Lake Franciscan Mission Fund, getting a collaborative effort with the College of Engineering at Louisiana State University. And it was an interesting journey to describe why we wanted to partner with industrial engineers. In people's minds, engineers build things. Where are they going to come build? We have buildings. We're good. And it's really about just looking at process and looking at efficiency and waste in ways that we in medicine, we look at every day and don't recognize. So when they come in and say, we have a problem, we're losing telemetry monitors. And that's probably something that you could likely go into any hospital, like, yeah, every once in a while we're short. How does that impact patients in the community? Well, when you're short on monitors, you wait in the emergency room, and emergency rooms are meant for emergencies, not for hospitalization. So there's increased length of stay. Things don't happen the way they should. And so fixing an inability to keep track of our equipment and make sure it's being utilized the best possible way for patients is what industrial engineers do. And they've been able to do some of those projects in our hospital. And we brought them into the clinics to say, look, we have this barrier, this challenge about getting through a social determinant survey in the time allotted for each patient as they're put through a template for a provider, because it really takes about 5 to 8 minutes to do it right. And if you screen positive, then you should go down the pathway and explore that like a medical problem. So we had them come in and capture some data. There was a nice record of where we end up spending time, where we could cut a few things off and make sure the provider's more efficient. Clearly, the good recommendations about stay in one system, don't have to go in and out, look at multiple websites, don't make it so complicated. And then we're now in the process of how do you recognize complexity so that we get another team involved to handle that. That's where the social worker, case manager, and care coordination comes into play about who does that. But they were able to put numbers to that and give us some perspective. The other collaboration we have is with LSU directly in the Lake. And that's just beginning. And I'm excited about that because that is access to deliver healthcare to students and athletes, in addition to getting to folks before social determinants have ruined their health. That's the upstream approach. And so we're now capturing at a phase where we can slowly start to see if we have a dip or a blip in a social determinant for a young person. We immediately address that because we want a very healthy community that's going to college, that's becoming professional, that's going to take care of me someday when I'm in a place where I need healthcare. And so what that brings to the table, as Jess just brought out with a great example of the University of Houston, is you have the College of Communication, you have the College of Business, you have analytics, you have social workers, and we're partnering together in addition to learning from each other because they have skill sets that we need to accomplish this goal. And so it's exciting. I mean, a big component of that is us supporting the care of athletes and learning a lot about that, but also a major collaborative, including LCMC, the institution in New Orleans, where you've heard Terry Sterling talk about before us about tackling cancer and making that a major point about when that diagnosis comes in, you have a world of things to now convert to supporting those types of patients, and also trying to make sure that they get the appropriate care across our state, across many neighborhoods and communities. So that can only be done by the connection of multiple institutions, in addition to the university system and the academic system, that is allowing us to think differently and also measure and readjust when things don't work. We have the data to point us in the right direction. So I'm excited going forward about that. And like Coletta said, I'm a lifelong student, and so they're teaching me analytics now. There's this coursework that I'm doing with the institutions we're partnering with, and it's interesting that one day they're in our hospital doing work with us, and another day I'm on a Zoom call learning about math. So it's been a great journey, and hopefully we will be able, if we continue to do this and invite us back, we'll have this is the data that comes out of this partnership. These are the people that have been helped, and there will be many stories, the mole story and the asthma, about getting rid of that as a trigger, bring in the concept of working with the community through these efforts, like in a disaster. Houston had a major hurricane. We're very familiar with that, and that's one of the ways in which mobilizing with the community. Again, Terry talked about 211 and Unitas and the resources that can immediately be brought together. The Cajun Navy, if you guys have seen them go into rescue modes, all of that to me is about health. I mean, you're going to get in trouble if your house has been devastated by a storm and now you are essentially trying to just survive and meet basic needs, and you have a chronic condition, it's going to get worse. So that to me is going to be an exciting journey we take when we have partnerships with the college, and we're also well connected. Claude, if you want me to mention the Baton Rouge community and the mayor's Healthy City initiative have also been tightly woven in, being able to address food deserts. And one of our partners in our own institution with LSU, Dr. Tiffany Ardwin, has been a big proponent of, the food nutrition, getting educational videos out to our patients, being able to participate in some of these efforts that are supported by multiple payers in addition to the city. That it's almost like when described, how do you do this? It's the elephant that you have to eat. It's one spoon at a time, and you have to be committed and consistent. And eventually, the task will be done. So hopefully I touched on all of those. There's so many I'm leaving out. There's some important ones, but those have been really great to be able to talk about, and just look forward into the benefit coming down the road as we sort of solidify what things we're going to focus on, and the specifics like Jess has described with their partnerships.
Well, we do have a question in our chat box that I think we need to answer live, because I'm certainly interested in hearing both of your perspectives on this. So this is from Jeffrey Hamilton. Thank you, Jeffrey, for sending forth this question. Jeffrey says, as we talk about collaboration and incentives, do you think that the bottom line, money, seems to always be the deciding factor? Then he follows up with a second question. Is healthcare legislation or the private sector activism is what we need?
Jess, you want to go first? Because I have my thoughts on that, but I'm happy to let you start with it.
Sure. So money is certainly not in the equation. It's an important factor, right? But maybe it's more about compensation and fairness. I don't think it always needs to be in the form of funding or dollars. I talked earlier about the relationship and really taking the time to understand one another's needs and priorities and assets and resources. And what you might learn in some of those partnerships is they have the funding, they need something else. And so really taking the time to understand the shared interest and the mutual benefit. And sometimes that will involve money and sometimes it won't. But if you take the time to build that Venn diagram, to really understand one another's values, you'll see where that shared interest and mutual benefit lies. And while the funding is important, I think perhaps more important is that relationship. And of course, that's a little bit of my bias. But I think nurturing the relationship can allow you to kind of troubleshoot some of more of those tactical transactional elements.
Yeah, I agree. I would say in place of money, the term resources. We have, the things that are needed to get the systems in place to provide what patients need. It sometimes does require money. You have to pay people. You do have to, invest in ways that you will put money in, provide food to a community setting that's got a food desert. But it's not always about getting more money. It's about choosing how to spend it. There are different ways that if an institution is, making a profit or even just, balancing, that you make decisions on where you're going to go with your strategy for health. And, sometimes that's buying a really fancy robot to do surgery. We have several and they're great. But sometimes it's also about, we need, this community workforce to support our primary care providers. And so it's the recognition of where, if I have limited resources, and we do, but if there was unlimited spending, we wouldn't have problems to talk about. So where do you sort of slice, this should go here, this should go here? And some of that, the relationship is the awareness of, if you fund this now at $10, you will recover 1,000 later. Most of the time it's a recovery in not spending money because of bad health outcomes. It's hard to see that value up front whenever you potentially can invest in other products that from a transaction bring in more money that's visible.
Mhm.
And so I think changing the conversation about it is wise to invest in preventative care and invest in health. It's just not recognized, immediately. Or is it in the same ledger of people who are there making decisions about where to put funding for the next 5 to 10 year cycle? So I do think, and you have your second question is legislation or activism. I'm always wary about legislation because good intentions, but sometimes bad consequences when there are rules that you have to do this because it doesn't allow the individualization part. But I do think that when you say activism, to me it's an awareness of what we've been doing is broken, and what we need to do, it doesn't immediately return an investment. It has to be faith in the system that if you solve these problems, your healthcare will be better, the costs will be better, and we can redirect where our focus is with our resources, and we've achieved the good goal of healthy communities. That takes time. That's not a 1 year, 3 year turnaround. That's a 5, 10, 20 year turnaround. And that's disappointing to some, but if you don't start somewhere, you will be the same 20 years from now without any change in what we do.
Mhm.
So great question. And it really is going back to what Jess said, it's a paradigm shift in thinking about how to provide health care. It really should start with addressing health to begin with, so that you are proactive in your efforts to minimize the things that in a social determinant circle result in expensive chronic care and bad outcomes for people.
Right.
Hopefully we got the answer to that, Colette.
Well,
Can I ask, because Colette is part of the panel and I know she's moderating, but I'm interested in your opinion because you are a multi-sector person every day.
every day. Where my brain automatically went was that economic decisions have moral consequence, no matter which way you go, and so one of the things, and I'll share a story. I was meeting with a group, another hospital group. They wanted to know about economic justice, talking about economics, right? They wanted to know about, programs. If we talk about community, and someone else brought the workforce up, our workforce is our first community. They are our first community because we cannot do what we need to do if they are not lockstep with us. And we have, the talent and the team that we need to implement our mission. And so therefore, our first community, it was with a group about their first community. I said, so tell me about your mission. And I got a bunch of looks around the table and someone said, well, I think it's about, academics or being the #1 research something. And I just went, oh, okay, well, guess what? Until you have a mission that speaks from the heart, you're never going to be able to get to seeing, this economic justice lens for your first community, because it's never always going to be about the dollar sign. It's never always going to be about, it's the mission component part. It's the heart that we bring to it. Yes, we talk about it all the time. No mission, no margin. If we don't create a margin, we can't fund the mission, right? And so they're all interdependent. But having the heart is what brings you to the table with these multi-sector collaborators. Having heart is what lets you step back and let someone else lead, because you're going to trust that we're all in it for the right reasons. And you have to let the process evolve. That's where I believe the leap of faith comes in, is you have to trust the process. if you've done what Dr. Dobbins and what Dr. Jagno said, is that we've looked at evidence-based approaches to this, and we apply these methods to these large-scale problems, trust the process as it evolves. And I think that's where nursing, as our, as our audience here, that's what you bring to this, is this evidence-based approach to looking at how we work in collaboration with others, and then let it evolve. Trust the heart. Trust the heart.
Awesome.
Thanks. Well, we just one last thing before we turn this over. Dr. Dobbins and Dr. Jagno, is there anything that you expected or you had hoped that we would share with this dynamic group? Earlier today we had like 180 something, participants out here. Is there anything else that you would want them to know about really quickly? I think we have like 3 to 5 minutes to be in to say, this is why we have to do these multi-sector collaborations. This is why we have to approach evolving health from this perspective.
Sure. I think the thing I've learned on this journey of, simply let's add screening to our health record. And that was, not clear to me how much of a challenge and how many people I needed that I didn't even know yet. Early on, we created a library with our social worker resources, and we required a data team to put that together. And I required a PhD who knew a background application in research called REDCap. So, as I think about when we started, there's at least 20 different roles, and multiply that times people that were required just to get started. So recognition of when you have complexity, it's going to take friends who have different skill sets, and that's the multi-sector partnerships that are required. And so we've been on the conversation about what payers can do, what providers can do, what other folks in the community can do, and without us sitting all at the table, executives, the finance folks supporting all of that. The first question he asked me, with the mission, it was from the top, we're going to do this, and everyone in the system was on board. And it's not really going to be successful unless we embrace that concept of this is not the sole responsibility of the doctor or the payer or the social worker. It's everyone working together to keep in mind the goal is going to require different practice, and we're going to have to work together to get there. Jess?
Yeah, gosh, I agree with everything that's been said. And of course, my bias is that the relationship, the health of the relationship and the partnership. We're obviously much, much stronger together, and multi-sector partnerships are just required for this really complex work. And so I think kind of back to Jeffrey's question, it's going to be that health of the relationship that's the rate limiter. So I would encourage taking the time to get that right, engage in the process improvement, identify and apply lessons learned. This is lessons from the industry, lessons from the literature. No need to keep making the same mistakes over and over again. And I don't know what the perfect recipe is for these multi-sector partnerships, but I think some of the key ingredients we've already touched on today: establishing the trust, identifying the shared interests, lock in leadership support and buy-in, take the time to develop, the appropriate incentive and infrastructure to make that relationship possible. And I heard Coletta in a previous panel, you referenced getting your house in order. Get your house in order, take care of that relationship, nurture that relationship. I think only then can you really tap into that synergistic power of the multi-sector collaboration. And that's what we're looking for. So,
and I guess I would wrap that up with Jeffrey with the conversation about maybe it's both.
Mm-hmm.
From the perspective of where there are structural opportunities to support community and public health, then yes, from a legislative perspective, there may very well be structural things that we have to do in order to make this work even more relevant. And from an advocacy perspective, it's incumbent upon every single one of us to be a part of that solution, part of that journey, no matter where we are in the continuum or what our role is. One of our, Charlotte Johnson, wanted to know what's the elevator pitch for nurses or providers to incorporate when talking about clinical workflows. I mean, I think we have to find our own language. That's the most important thing, is you have to find your own words as to how you convey that health is more than just the stethoscope on your skin. And so we want to be a part of solving that collectively. And it's going to take all of us to do that for sure. So combination of being an advocate and where there are structural barriers to be broken down around social needs, then I think that's where the legislative administrative rules come in. Let's talk about administrative rules with our Medicaid, program and plans. So excited this year to see the incorporation of community health workers as a requirement in those managed care plans, so that we can take change to the community level. Subsidiarity right there where it's happening at the level of the patient in the community itself. So very, very exciting things evolving. So find out more, ask the questions, figure out where your organization is in the journey to addressing social needs, and get engaged and involved. I'm going to turn us back over now to Miss Lisa to bring us to glory.
Ms. Coletta, I just want to really thank you and for inviting Dr. Dobbins and Dr. Jagno to this conversation today. We have to all work together to make things, come together and be appropriate. At the end of the day, it serves our patients. That's what we're all about. So thank you. Thank you so much.